then appendicitis, I think I'd already mentioned before, I think through our learning when we are talking about inflammation. Of course, that's a common presentation. Somebody comes with fever, somebody comes with vomiting, they come with right iliac fossa pain. I know you should know where the right iliac fossa would be. And then, of course, you do some tests, you fullomogram and so on. Then you do maybe palpation, then there will be tetanus around that time. Then you think about acute appendicitis. And of course, if you look under the microscope in the mucosa, there will be ulceration of the mucosa, transmural acute inflammatory infiltrate. When you talk of transmural, though it's going through the entire wall. So talk of transmural, that is inflammation is going through the entire wall. So the mucosa, submucosa, the muscle layer, all the way to the serosa. That's what we mean by transmural acute inflammatory infiltrate. So there will be those infiltrate like neutrophils all over the wall. Then, of course, if it's not well controlled, it can lead to necrosis of the wall. It can lead to gangrene, that is the dying of the tissues. And if they die, finally, it will perforate. Yeah. So there's neutrophilic infiltration of the muscularis. So it's affecting the entire wall. And acute appendicitis is common mostly in older children and young adults. So maybe your age and older children. So it's rarely common in very young children, and it is rare also in older people. Yeah, so this is where the most common area in older children, young adults. And you see the mechanism there would be mostly is obstruction of the lumen. Remember, the appendix has a lumen, so it can be obstructed. And if it's obstructed, of course, there is accumulation of discharge that is within it, and it's likely to become infected. So what happened? There is a decrease of intraluminal pressure. So the pressure within the lumen of the appendix become increased. Yeah, and that in itself is what may cause necrosis of the tissues. And of course, the treatment will be appendicectomy, where you go and remove the appendix completely, or you can also give antibiotics. Sometimes in acute appendicitis, sometimes it can even deal with antibiotics. And that is a picture of acute appendicitis, a diagram rather. So you can see there is a impacted concretion. That could be a fecolin, as in a very hardened stool that entered there and stayed there and became like a stone, and it can block it. It can be even a worm. If it enters there and it blocks it, but mostly in children, it tends to be enlarged lymph node that is around the appendix that causes it to become blocked. And so you end up with congestion of the vessels, and all the sequelae will follow if it is not dealt with early. And of course, that is acute appendicitis. Histologically, that's a diagram, of course. You'll have congested vessels, necrotic mucosa, and neutrophilic infiltration in the muscularis. So if you look at the muscularis, that is where that is the muscular layer, the smooth muscle, the inner circular, outer longitudinal. You find a lot of neutrophils within it, neutrophilic infiltration. Enterobius vermicularis, that's pinworm. Most of the time, this worm is usually an incidental finding. That is something you are doing something else, then you find it. So rarely it is not, most of the time it is not symptomatic. So most of the time it will be an incidental finding. So pinworm section seen within the lumen of an appendix. So usually after appendicectomy, you remove the appendix, and most of the time we send it to the pathologist to look at it, just to confirm there was no cancer within that appendix. And sometimes when they are looking at it, they see sections of pinworm, because the pinworm was actually inside the lumen of the appendix. But also, if there are many, it can cause obstruction of the appendix. They are also called threadworms. So you'll be able to look at them even in more detail, and I'm sure in parasitology, we probably will mention it. And how is it spread? Usually fecal-oral route. That is basically contamination of water, food. We call it fecal-oral route. So basically, it's like you're taking stool. You're basically taking in stool that is contaminated with those parasites. Yeah, and usually it doesn't get into tissues, so it doesn't invade the tissues. So female worms, that is of the threadworm of Enterobius vermicularis, lays eggs in the perianal area. So usually it comes out at night especially and lay the eggs around the anal region. And symptoms, if any, tend to be perianal instead. So some people may have, maybe early in the morning, they feel a lot of irritation around the anal region, and so they will be scratching there. And that is how sometimes it's spread, because you scratch it, then swallow the eggs again. when you use your hands. And so those eggs again get into the intestine, mature, and the cycle repeats. So, but the adult worm inhabit the ileocecal area and are most commonly identified in the appendix. So most of the time they get into the appendix.